Now this is a story all about how to deliver drugs to the ovaries now, and I'd like to take a minute, just sit right there. I'll tell you about how to do it and why you should care. In girls undergoing chemo IV drip, a drug called Doxil makes the ovaries quit, killing cells causing infertility. But there's a drug called dexrazoxane with the ability to combat Doxil and save the ovary cells. Started making quality of life swell. It's just one little drug, and it's got to be delivered to just the ovaries, not other organs like the liver. Designed and tested a cuff day after day. We put some microneedles in an array. We modeled the vessel and we modeled the system. As far as the options go, I might as well list them. First pass, all the choices we had. Pre-treating, coating, hollow needles, and rad. Is this what the treatment is gonna be like? This might be alright. But wait, I hear they dissolve with the drug encapsulated. Are these the type of needles that we have created? I don't think so. You'll see what I did here. I hope you're prepared for the PDMS square. Well, 10-to-1, and when it came out, put it in the vacuum desiccator to get the air bubbles out. I ain't trying to get bubbly stuff, got a pinpoint. Poured with the quickness of lightning around the points. I waited for curing, and when it was done, put the microneedle membrane in an arterial cuff. If anything, I could say this device was rare. Thought, don't forget it, you'll find when we're here. I pumped tripe and glue through about 3 mils per man, and I put round a vessel. Yo, it's a conduit. I let it pump through, push through the tissue, solve the transport equations. It had 0 issues.
The video you just watched contained a brief summary of a design project for Biomedical Engineering 550, Biological Microelectromechanical Systems. The proposed device includes a 3D printed shell of an arterial cuff that would utilize a microneedle array embedded in a semi-permeable membrane to provide a reservoir for dexrazoxane. Dexrazoxane, as described in the music video, is a drug that counteracts the effects of doxorubicin, trade name Doxil. Doxorubicin is a chemotherapeutic drug, an anthracycline, which acts as a topoisomerase inhibitor, as well as a factor in increasing oxidative stress in the heart. In the case of women undergoing chemotherapy treatment, premature ovarian insufficiency is often a result of acute apoptosis of granulosa cells from the side effects of Doxil. The proposed device will address the issue by offering a novel delivery system that counteracts the damaging effects of Doxil. Dr. Sana Salih of UW Health has investigated the potential use of a chemoprotective drug called dexrazoxane to combat the adverse effects of Doxil. The main challenge in applying what we currently know about dexrazoxane is in creating very accurate targeted delivery of the drug. Dexrazoxane should only counteract Doxil within the ovaries, not systemically, in order to allow for the chemotherapeutic drug to effectively kill cancer cells. The suspensory ligament houses the ovarian artery, a vessel which solely supplies the ovary with blood and nutrients. This ligament, shown here in an anatomical sketch as well as in a picture of a bovine ovary with the ovarian stump. The stump is the suspensory ligament cut to show its cross-section. In cows, the ovarian artery is actually a cluster of a few small arteries. Ideally, the design arterial cuff would surround the suspensory ligament and provide controlled release of dexrazoxane only to the ovaries. From content learned in Biomedical Engineering 550, our team designed a proof-of-concept device incorporating pseudo-microneedles into a PDMS thin layer, which would act as the microneedle semi-permeable membrane. We used adhesive to attach this membrane to a 3D printed shell with an opening for a port, which would allow for controlled flow of a solution with dexrazoxane into a reservoir. The technology needed to fabricate these needles of micron dimensions was not widely available until the 2000s. Currently, low-cost mass production techniques of the microelectronics industry has allowed microneedles to be fabricated from silicon, metals, and several other materials. Similarly, microneedles are currently fabricated within patches used in transdermal drug delivery systems. Microneedles are advantageous in that they allow large molecules to be administered, they decrease microbial penetration compared to hypodermic needles, they enhance drug efficacy and may result in reduced dosages, and offer rapid drug delivery through coupling with electronically controlled micropumps.
So as Emily discussed, we wanted to create a cup that would be secured around the ovarian suspensory ligament, which houses the primary blood supply to the ovary, and deliver the chemoprotective agent to the tissue. Due to resource limitations, including resolution requirements of 3D printers on campus and the unavailability of tissues, we determined a proof-of-concept design would be used. To begin, we created the plastic casing, the cuff portion of the design. This was modeled in the CAD software SolidWorks. We chose to create a hinge design that would clamp around the ligament for ease of attachment. The cuff measures about 22 millimeters across and 12 millimeters tall when closed. Looking at the figure, you can see a port at the top that allows for PICC line attachment for multiple doses that goes into a reservoir which will fill with the chemoprotective agent. We saved this CAD file as an STL and printed it using a MakerBot replicator as seen here. Additionally, we created a framework for a vessel in SolidWorks and 3D printed it using the MakerBot. This serves as a scaffold with which we surround with a semi-permeable membrane. The semi-permeable membrane was created using parafilm that was manually perforated. Now that we have an ABS arterial cuff, we needed to create the microneedle membrane to close off the drug reservoir and interface with the mock vessel. We decided to use Fisher Scientific pipette tips for this due to availability. We began by creating a 4x4 plastic spacer that would serve as a mold to secure the pipette tips in place, allowing for a controlled arrangement of the tips and constant tip extrusion height. We placed the tips in the spacer. The microneedles extended approximately 3 millimeters from the superior surface. We then wanted to cast PDMS over the microneedle array, so we mixed PDMS at a 10:1 ratio of polymer and curing agent. We mixed the solution for 60 seconds until bubbles were present throughout, then placed the PDMS in a vacuum to degas the polymer. After 30 minutes, the PDMS was removed and poured over the microneedle array. It was cured at 100 degrees Celsius for 45 minutes, and embedded microneedles resulted. The plastic spacer and excess portions of the pipette tips were removed, and we were left with the microneedle membrane. In order to increase the likelihood of diffusion, we plasma treated the membrane at 60 watts for 60 seconds to make the surfaces hydrophilic. The microneedle membrane was then attached to our 3D printed cuff to create a drug reservoir using epoxy. Now that our device was fabricated, we clamped the cuff onto our simulated vessel, puncturing the model vessel wall. Using an automatic syringe pump, water was pumped through the simulated vessel and into a beaker while trypan blue was pumped into the cuff. As the trypan blue was pumped into the drug reservoir, it was pushed through the microneedles and into the vessel, ultimately flowing into the beaker below. During this testing, the pressure within the drug reservoir increased and began to leak through the epoxy seal as well. This will need to be improved in future iterations. We were able to successfully create a macroscale model of this arterial cuff design, but in order to achieve sustained drug delivery to a vessel, significant improvements need to be made. The primary aim of our future work will be to employ photolithography methods in order to have submicron resolution in fabricating our microneedles. We will employ anisotropic etching of chromium-doped PDMS wafers in order to create hollow silicone microneedles. Following Mahedevin et al. From McMaster University, we will look to create microneedles that penetrate the vessel by 140 microns, and the tip of the needle will have a radius of curvature of less than 100 nanometers in order to puncture the vessel wall with minimal pressure applied. Decreasing the size of the microneedle will inherently allow us to embed them in PDMS at a high density, increasing contact surface area and thus increasing drug delivery. Additionally, we will need to decrease the overall size of the device, which will require a 3D printer with better resolution. Additionally, as we look to make this device clinically relevant, we will need to investigate bioresorbable polymers, at least for the microneedles and membrane, as tissue integration is a serious limitation for devices implanted longer than 6 months. Researchers have had varying success at replicating the features fabricated with silicon photolithography with resorbable polymers such as PLA and PGA. Finally, once the device has been optimized to achieve sustained and reliable drug delivery, we will need to test the design in vitro using bovine or human ovaries. A group at the University of Wisconsin, under the direction of Dr. Sana Sali, has created an ovarian bioreactor that is designed to sustain the life of the ovarian tissues in vitro. We will be able to deliver the chemotherapy agent to the tissues and place our cuff around the suspensory ligament within the bioreactor and deliver the chemoprotective agents. We will then take histological samples and perform lab-dead assays on the tissue to determine the efficacy of drug delivery to the tissues and thus validate our design.
Another application of implantable microneedle arrays for drug delivery has been studied by Geetha Mahadevan at McMaster University, which uses similar technology as discussed previously in order to treat age-related macular degeneration, or AMD. AMD is the leading cause of irreversible blindness among elderly patients within the U.S. It affects more than 17 million people in the U.S. and is the leading cause of blindness in the developing world. Neovascularization and leakiness of the vessels in wet AMD represents 90% of AMD cases that lead to blindness. Here's an image depicting vision loss as AMD progresses. Despite the important role of angiogenesis, it is only within the last 10 years that anti-angiogenic drugs have been applied as a wet AMD therapy, such as antivascular endothelial growth factor, or VEGF, agents. The use of these drugs has serious side effects and risks, such as retinal detachment, vitreous hemorrhage, and cataracts. The invasiveness due to the need to inject anti-VEGF treatments repeatedly into the eye is difficult for patients and increases the chances of consequences. Anti-VEGF injections also tend to be less effective as the disease progresses, and VEGF itself is necessary in retaining normal ocular function. Therefore, there exists a critical need to identify alternative treatment strategies and to test less invasive methods for treating wet AMD. Mahadevan studied the potential for creating a flexible PDMS substrate with hollow and rigid microneedles to demonstrate molecular weight independent release of drugs, made glass hollow microneedles in flexible substrates, and demonstrated ex vivo delivery of rhotamine to various layers of the posterior eye at controllable nanoscale flow rates. Just as discussed in the main theory of our dexrazoxane delivery device, he varied concentration and fluid pressure to control flow of drugs into a given layer of the eye. His proposed devices decreased invasiveness by being non-implantable and biocompatible. When fabricating PDMS substrates for embedding microneedles, Mahadevan and his team performed first replica molding, then delaminated the PMS from the master mold, patterned it, aligned an unpatterned section with a patterned one to react the two halves of the device, punched holes through the patterned spaces, bonded the sections with plasma surface exposure, which is a method that makes PDMS hydrophilic and irreversibly self-adhesive. Then he fit glass tips in certain experiments into the microchannels and bonded the tips into the PDMS by curing rapidly. We bonded our pipette tips, quasi-microneedles, into PDMS molds at 300 degrees Celsius in a less precise but similar fashion. Mahadevan explored various methods for fabricating microneedles, including a few newly proposed techniques of co-opting simple etching normally used for optical probes to avoid expensive photolithographic techniques while still creating high aspect ratio microneedles. Here we have outlined the work of Mahadevan in his thesis research, and we have talked about our exploratory research from what we learned in bioMEMs. The applications of various microneedle drug delivery systems are rapidly expanding, and we highlighted just a few techniques and applications here. Thank you for your time. We hope that you learned a little bit about microneedle fabrication and its new applications.